So today I will be discussing the digital technology milestones at Rutgers School of Dental Medicine, and for our school, this is just the beginning. So I would like to talk about strategy and planning, implementation, training, quality assurance, and IT challenges. I will begin with our strategy and planning. The first step for us is to assemble the Advanced Digital Technology Committee by our Dean, Dr. Feldman. And that included a faculty from each department, so it was a school-wide project. 2 faculty from our department, the restorative dentistry, because we are one of the biggest departments in our school. We also had the Senior Associate Dean for Clinical Affairs, and most importantly, we had the Executive Director of IT and another manager from IT. The charge of this committee was to integrate the digital dentistry into the curriculum for predoctoral and postdoctoral programs. And in our first meeting, we established our goals. So our goals were to enhance the quality of dental education, to keep up with the innovative modalities of digital dentistry, and to increase the applicant pool. So we've talked about this. When we interview the applicants, the first question would be, what kind of digital equipment do you have? Do you have any? So we wanted to target a more sophisticated pool, otherwise the other school would be more competitive than us. And also create research opportunities for faculty as well as students, and graduate dentists who has the ability to implement this in private practice as well as academia. Also a big financial advantage of the clinical revenue and through continuing education courses. We began that with a SWOT analysis, and that include the bullet points of strength, weaknesses, threats, and opportunities. I would like to focus about the weaknesses. So there was a study in 2009, and they found that 50% of companies cited resistance as one of the main challenges when they changed the business software. Another survey of 500 executives in 2011 cited resistance as the primary reason why changes fail in big organizations. The threats would be mainly your school regulation, university regulations, IT regulations, and that would also affect the digital workflow and data transfer. By the workflow, what I mean is you have an intraoral scanner and an oral lab scanner that needs to communicate with a milling machine or a 3D printer. So that workflow in your institution is actually more important than the machine itself. What happens is sometimes what you can implement might not be what you want to implement. So just you have to keep this in mind. So we started the journey by having meetings with different representatives from different companies, and the key of success is to have an IT staff. So I had Travis from IT assigned to me, and he was there in every single meeting asking questions and writing notes. Based on those meetings, some systems were excluded. They were not compatible with our IT and our school. So in our second meeting, we presented comparison of every system that can be utilized in our school. And based on that comparison, our committee was able to make some recommendations. So the recommendations was, for the preclinical education, we decided to purchase intraoral scanners together with a self-assessment software, and we decided to go with Compare. The reason why we chose Compare software is because it engages students and it enhances their understanding. Also, it frees up time for one-on-one instruction, and that is useful if you have a deficiency of faculty like most dental schools. For the clinical education, for pre- and postdoctoral programs, we decided to go with Trias intraoral scanners, and the reason is it has the highest trueness and precision, powder-free, colored, open system, and like Dr. Wu mentioned, it has so many design softwares and applications. The recommendations of the committee had to be based on evidence. So we had to read some articles, and one of them, this publication by the American Academy of American Dental Association. And according to that article, the Trias intraoral scan had the highest trueness and precision. In March 2017, we were so honored to be selected as one of 5 pilot schools nationwide by the ACP Digital Dentistry Initiative. And in the same month, we visited 2 schools to seek their advice. Columbia Dental School, and then Medical University of South Carolina, who was our mentor, specifically Dr. Mark Ludlow. We were so much honored for him to be our mentor. Most importantly, the business plan was developed and approved by the school dean in June 2017. Our school, unlike other schools, decided to implement in phases, phase 1, 2, 3. And the reason is, you will have less financial burden on your school if you implement on phases. Also, that implementation model will help you to switch to other equipment should something else come in the market that is more advanced or user-friendly. So in phase 1, we decided to purchase the preclinical plan scans and the compare software, 2 scanners of Trias for the postdoctoral programs, collaboration with the PDS Stone Glass Digital Dentistry Lab, and the 3Shape design software. Phase 2, which is this year, 2 additional scanners for the pre-doctoral clinics, and we also hired 3 registered dental assistants. Phase 3 next year will be adding 2 more scanners, and so on. So let me talk about more details about the implementation phases. Last year, 2017-2018, we completed our phase 1 successfully. So we did purchase the plan scans and the compare software. We also renovated our computerized assessment laboratory, and we got 2 Trias scanners for the postdoctoral clinics school-wide. By that I mean those scanners are shared by prosthodontics, periodontics, oral maxillofacial surgery, pediatrics, and general dentistry. We also acquired the 3Shape design software. The main courses that taught the scanning and compare at the beginning was the preclinical operative in first year and the preclinical fixed pros in the second year. Since our class size in preclinic was still 96 students, so we have a ratio of 1 scanner per 8 students, which is a very decent ratio. So this is the first renovation of our computerized assessment laboratory. And we opted not to deploy the laptops from the company. Instead, we purchased our own Dell workstations, which are matching our university standards. What was also a great achievement from our IT department is to integrate Romexa's software with axiUm Mannequin. Romexa's software is the scanning software for plan scans, and axiUm is our electronic health record. By doing that, the student can log into axiUm Mannequin. They can click on this imaging icon, and now they are in the Romexa software. So what is the advantage of this? In other schools, if a student scanned from a certain laptop, they can only access their scan from this laptop. But for us, if a student scanned from any workstation, by logging into axiUm, they are on the server, so they can access their scan from any workstation. Not only that, but also our IT was able to allow us to take screenshots of the compare and upload that in MIPACKS, also integrated with axiUm, as if it's a panoramic radiograph. So we ask students to take a mesodistal shot, buccolingual shot, occlusal shot, and then that can be evaluated by the faculty. In January last year, 2 scanners for the postdoctoral clinics were purchased, and we decided to use train the trainer model in our school because we are a big dental school. So 2 faculty and/or residents from each department would acquire an official training in the 3Shape facility. They come back and they train other faculty and other residents. We also trained our laboratory technicians. This is the second renovation of our computerized assessment laboratory now. And we also collaborated with the Department of Endodontics, so they can use the same workstation for their Sorodex Digora Optima. Phase 2, which is still going this year, was mainly to integrate 2 major courses, basic dental anatomy and occlusion, to create one combined course, dental anatomy and occlusion. And the reason we did that is to free up a space in our curriculum so we can establish a new course, which is the pre-clinical digital fixed prosthodontics. So that is the main course now that teaches the first-year dental students how to scan and use Compare. We just ended this course 10 years ago, and after each course, the students have to submit evaluations. And we got those 2 comments, one of 2 comments out of several comments by the students. Basically, what the student is saying is the Compare allowed her to see the undercuts, and she was struggling with the taper, she was struggling with the finish line thickness variation, and she was impressed by the fact that the Compare would provide a numerical value in degrees of taper and thickness of the finish line, and instead of just subjectively getting the feedback from faculty. Another student mentioned that at the beginning, she was struggling with 35-degree taper, and by the second or third time, she was able to achieve the 12 to 15-degree taper. So what she's saying is the first scan, she got graded 86%, and by the third time, the Compare now is grading her for like 94%. And that was a great motivation for that, for students. In phase 2 this year also, we have 2 TRIAS scanners for the pre-doctoral clinic. So now the challenging part really to us, because we're a big school, is training. What we did is we developed different training strategies for different communities of interest. So we have training of faculty, dental assistants, postdoctoral students, preclinical students, and clinical predoctoral students, and each has a different training protocol. For training faculty, we started last September, and it's still ongoing. I started by training the dental assistants that we hired, and then I trained only 3 faculty. Now, each faculty will train 2 additional faculty with the help of a dental assistant. So far, this model is working well, and it works well with a big department, because in our department, we have 60 faculty. For the postdoctoral pro student, we have 15 students. We have 5 in each class. What we did is we chose a student trainer from each class that had an official training in the 3Shape facility. They come back and they train their classmates. And in the preclinic training, we had a different model. What we did is we would ask 1 faculty to train 3 students only, and then each student would train their classmate. The feedback from this model was really interesting, because the students mentioned when you learn a technique and then you teach it to another classmate, you learn more, you become more familiar with it. For the clinical training, and as you can see, we have a relatively big class size. We have 124 students in the 3rd year and 124 in the 4th year. Our clinic system is based on 4 groups, A, B, C, D, and in every single day, 1 clinic is available because the students are rotating, for example, in the university hospital or in the pediatric clinic. So in that available clinic, we have the digital training, only 6 students at a time. The quality assurance and quality control was a big deal. For a couple of months, we didn't know how to make this for the digital workflow, but eventually we were able to develop a detailed workflow for mainly 2 reasons. To ensure that any case is financially approved before the lab processes the work order, and to make sure that the case will pass QA before it is sent to the lab. So we have two ways to do the quality assurance in our school. If you have the 3Shape design software, you can actually compare a three-dimensional image. If you have only the Trias intraoral scanner, you can still do the QA, but in a still image, and I will explain both. So with the 3Shape dental software, you can 3D move the image, and you can evaluate the occlusal, the buccolingual, and the mesial. And you can also take advantage of this tool that will let you measure in fractions of millimeters the interocclusal clearance. However, if you only have the scanner, we can ask the student to take screenshots of occlusal, buccolingual, and use this great tool from the 3Shape to numerically measure the clearance. We also require them to do the digital die trimming, similar to trimming your conventional die. Then those images are saved and shared with the QA faculty. axiUm Scheduler was a very helpful tool. So this will allow the students, whether in PG or undergrad, to schedule the scanner ahead of time. So the dental assistant knows how to move the scanner to which clinic, what time in the day. Finally, the IT challenges, and that's like quite a bit. For the pre-clinic plan scan, the IT was able to integrate room access to axiUm Mannequin, like I just mentioned, and also to have a centralized storage so any workstation can be utilized. The compare would also allow the student to take the screenshots. And again, we used computer stations instead of the laptops. But we had some hiccups. So we had instability during scanning, meaning the scanners were freezing. And the solution was to update the FireWire card power cable in order to solve this problem. For the scanners in clinic, we also have centralized storage so we can back up all patients' data. And because all the licenses are combined into one dongle, we can access any of these scans from any workstation. Those cards are really useful because they can secure the laptops together with the scanners. To summarize our strategy in that journey, strategy is a key. So engaging your school leadership, whether it's dean or the assistant dean for clinical or academic affairs, and the IT committees. So what you have to do is you have to have progress meetings with the dean. And also you have to have meetings with the faculty in order to encourage them and engage them so they can adopt this new technology. Otherwise, you might have resistance. I cannot emphasize how important to engage the IT from the beginning. So I am the chair of the Advanced Digital Technology Committee, but I also report to the Clinical IT and the Academic IT Committee, which reports to the IT Governance Committee. The resource needs has to be defined from the beginning. A business plan has to be structured, and a training plan, again, different for students versus faculty versus assistants. The learning objectives and competency has to be part of the curriculum, so you have to have meetings with the course directors from the beginning. A communication plan to get the students' feedback is paramount. So as I showed you, some of the comments from students, whether it's a positive or negative feedback, will help you to improve yourself. Communication is a key factor, and by that I mean communication to alumni, communication to new patients, and communication to prospective students and residents. So, as you can see, this initiative was featured on the front page of the Rutgers annual report. The ongoing project now is to develop axiUm digital codes. We are getting a donation from Henry Schein for 3 chair-side milling machines. And we are planning to integrate room access into axiUm production. We're also planning to use compare software in dental anatomy and occlusion. We are also now in the phase of construction of a digital education center, and that is sponsored by Stone Glass Laboratory. Finally, I would like to share this quote with you by Rohan Oza, who's one of the Shark Tanks people. People who want to make a difference are always going to have pushbacks. You have to have the inner confidence to push through, because if you do not break through that wall, you will get stuck behind it. I would like to thank our chair, Dr. Stephen Morgano, the Associate Dean of Clinical Affairs, Dr. Michael Conti, and all those amazing faculty from our departments who are key leaders and key training in this initiative. Thank you so much.